Thank you so much for having me. It's a pleasure to be part of this international congress. I'll be speaking today about the biggest threats to anesthesiology. My Twitter handle is at the bottom of my slide and on the top of all my other slides. So I hope that you will share everything that you learn and continue the conversation even after the presentation is over. I have no financial disclosures. And in case you fall asleep for the rest of the presentation, the three main threats that I perceive for our specialty are loss of identity, fear of technology, and resistance to change. So what do I mean by that? So let's talk first about loss of identity. Almost every day in operating rooms around the world, we have many of our colleagues in anesthesiology counseling their patients about the upcoming anesthetic for their surgery. And sometimes we do this ourselves, where we talk about general anesthesia as being sleep. Well, I'll give you this medication that will start you going off to sleep, for example. I think that really does an injustice for the complexity of what anesthesia really is. For example, sleep, which many of us did just last evening, is natural. It's restful, we dream, and we wake up, hopefully, if we've had a good night's sleep, well rested and energetic. That's not the same as anesthesia, which I think is very different. When we look just 2 decades ago, anesthesiology was actually identified by the Institute of Medicine as being a specialty that took important strides in terms of patient safety. Anesthesia wasn't always so safe, but because of technological advances such as the pulse oximeter, standardization of equipment, changes in training, anesthesiologists around the world were able to take on major, sustained, widespread reductions in morbidity and mortality after surgery. I think this is taken for granted today, and I think it undersells the value of anesthesiology. When we look at books such as The Invisibles, where anesthesiology is actually listed as one of the 10 most underappreciated professions, this should give us some idea about the way that the world perceives anesthesiologists. There are some positives, of course, and the way that the author describes anesthesiologists is that they naturally have this ambivalence towards recognition. And I think that there is some truth to this, of course. Many of us who entered the field of anesthesiology and were called to this profession were not looking to be the headliners. Otherwise, we would be surgeons. We chose anesthesiology because of the work that we do and the importance and value that we bring to patient care. However, that ambivalence towards recognition can sometimes backfire on us, especially as we become perceived as being anonymous. When I look in the United States at how the practice of anesthesia keeps changing, one of the big trends that I've seen is this conglomeration of small groups into very, very large practices, some of which span multiple states within the US. This is an example of a search committee that contacted me about a new job. The company was called Sheridan, and they were looking for a vice president for perioperative services that would basically manage all of the anesthesia practices within a 4-state area. As you can imagine, the standardization of practice that comes along with that is mandatory in such a large group, but really takes away in many forms the individuality and skills of the anesthesiologists. I think the concern as you look at these large conglomerations of anesthesia practices is that being part of 27,000 strong anesthesiologists and other healthcare professionals, it doesn't make one feel very valued. And I think this is really an issue for us moving forward as a profession, because we know that physician burnout is real. When you think about the practice of anesthesiology as being necessary for surgery and so many other developments in invasive procedures within our healthcare systems, you can see how anesthesia drives the innovation. It drives the ability for other specialties to perform their procedures and for health systems to deliver care. But when this happens, when you become a workforce that is very, very service driven, then I think the concern really is that part of our burnout is really loss of identity. And I have strong concerns about this, looking at our anesthesia workforce of the future. When you become part of a group of 20,000 individuals, then you can imagine your ability to feel like a valued member of the team as a physician who has answered the calling to medicine becomes very difficult. And Dr. Alexander and Dr. Ballou, they listed 3 symptoms of physician burnout as being a feeling of lack of accomplishment, cynicism, and loss of zeal, zest, and enthusiasm for work. How many of us have ever felt that way? And I think we have to really question whether all burnout is really the same, or if some of burnout is really this anonymity, or it's really the loss of identity and loss of a connection to the field and calling of medicine. I feel like that's actually one of the big concerns for me. The next threat that I perceive is the fear of technology, and this has been going on for a long time. One of our studies performed here at Stanford looked at an algorithm. And as you can tell from the headline, can an algorithm diagnose pneumonia better than a radiologist? The answer obviously was yes, because this was a very highly talked about article when it hit the lay press. Researchers developed a deep learning algorithm that could evaluate chest x-rays for signs of pneumonia. And what they found, not shockingly, is that the diagnoses based on this algorithm from chest x-ray images were able to diagnose 14 types of medical conditions better than an expert radiologist working alone. And I think this is something that we as physicians, and not just as specialists in anesthesia, have been looking at as a potential threat to our existence. However, so this actually impedes progress in many ways. Look at target-controlled infusion. The PK/PD algorithms for target-controlled infusion were developed, at least in some part, by one of my colleagues, Steve Schaefer, when he worked here at the VA Palo Alto. We've had data on target-controlled infusions and the ability to use them for care for decades. And while they're available in other areas of the world, they're still not available in the United States, which I think is really interesting considering the contributions that American anesthesiologists and scientists have had to the development of these algorithms. One of the big controversies in the last few years was the development of closed-loop propofol delivery systems. To the extent that the Washington Post actually titled this article, "A New Machine Could One Day Replace Anesthesiologists." And when we all know that that is not true, but the inflammatory nature of the headline definitely got some attention and made even those in our own profession somewhat concerned about what the role of these advanced technologies could be for anesthesiologists in the future. So much so that our national society, the American Society of Anesthesiologists, was one of the more vocal opponents of this type of technology. And eventually, Johnson & Johnson, the company that produced this, this particular piece of equipment, pulled it from the market, and it hasn't come back since then. The third threat is resistance to change. And this is a problem not just in anesthesiology, but in all of healthcare. And I think that we've all heard this phrase. We've always done it this way. I've heard it in every place where I've worked clinically since I've finished my training. I think this is a challenge because every time we have new evidence, we should be constantly inspecting our practice and deciding whether or not our practice needs updating. When we look at the time frame for changing clinical practice, the length of time, the latency, is completely unacceptable. The headline of this article was, "The answer is 17 years. What's the question? Understanding time lags in translational research." And it actually shows within this first figure a conceptual model of how evidence eventually becomes a change in clinical practice. You can see there are multiple important milestones. We have two different types of translation. There's translation from basic science research to human subjects research, but there's also the knowledge translation when we get results from human subjects research and clinical trials, and then we create evidence-based guidelines and then eventually transform clinical practice. That whole process is estimated to take 17 years, which is completely unacceptable, especially for many of us who are actively taking part in generating evidence that we hope will influence the care of our patients. When you look at the barriers to change, there are many, but they're not exactly what you would expect. And I know when I talk to my colleagues in anesthesia about regional anesthesia, for example, the most common factor that gets mentioned to me, at least, is, oh, surgeons don't really want that. But when you look at the different categories that include barriers to change, you'll see that the external barriers are only one category. That's what I labeled as them. The great majority of barriers to change are actually internal, and I labeled those as us. Things that we can control, or things that are internal or intrinsic barriers, are things like lack of familiarity with evidence or lack of awareness that evidence exists. Sometimes it's attitude related, like you don't think that certain types of evidence or available guidelines even apply to your practice, or you don't think that it would work in your particular situation. It's okay for them where they are, but it's not going to work for me. And for some people, it's really just a lack of motivation. It's just plain old inertia. They don't want to change because they've always done it that way. So what do we do? So I didn't mean to present all of these threats to suggest that there's nothing possible that we could do, because that would be hopeless. And as physicians, we practiced for 30 years. So I would never want someone to think that how it is now is how it's going to be for the rest of your career. And I don't believe that that's true. I think we have a few options, and sometimes the decisions aren't always easy. So when you look at loss of identity, the way that we address that as anesthesiologists is to establish a brand. And what do I mean by that? It's not, although it's a marketing concept, basically what it means is that anesthesiologists have to be known for something. We can't be anonymous. We have to be out there and be visible, so that way the value that we bring to patient care is recognized within our health system. How do we do that? Well, right now we're in the midst of the COVID-19 pandemic, and anesthesiologists were, for the first time, featured on the cover of Time magazine. I think that there's some recognition about what we as anesthesiologists bring because of this crisis. I think that people understand our special skill set, especially as it pertains to airway management, acute respiratory care, critical care. But at the same time, we've always had an identity, even before the pandemic, and I think it's important that we remember that as well. For example, there have been, for many years, we've talked about the movement towards more personalized medicine. But I would argue that anesthesiologists actually practice the most personalized form of medicine. We do this every single day in our operating rooms. No two anesthetics are ever the same, because the way that each patient responds to medication, responds to the stress of surgery, responds to the interaction of stress plus pharmacology, blood loss, pain, or noxious stimuli, all of these factors influence the way that we respond as anesthesiologists in the care of our patients. So we've been doing this already, but I don't think that we always are very explicit about saying that we as anesthesiologists deliver personalized medicine when we do. When we look at Professor Emory Brown, he has for years tried to remind us that anesthesia is not sleep. As I mentioned, when we call anesthesia sleep, we are doing ourselves a disservice. When you look at the patterns of EEG for patients under anesthesia, this is more like a coma, is what Professor Emory Brown says. And I think that we do our patients a very important service by reminding them about how we provide anesthesia, what it means for them physiologically, and how important it is for them to have a physician specializing in anesthesia taking care of them during surgery. I think that this is a very important reminder, and I hope you take this away. So anesthesia is a reversible coma. It's not sleep. I also think it's important that we as anesthesiologists be visible. We have to know when to take the mask off and go to meetings and participate in our hospital leadership, because I think this is the only way for our colleagues to really understand who we are and what we bring in terms of value for healthcare system operations. These are just some examples of my anesthesiologists with whom I work at our hospital. We have multiple chairs and co-chairs of hospital committees. We've had a history for many decades of being heavily involved in the leadership of our hospital, including having an anesthesiologist chief of staff years ago. I think this is really important because I think it allows our colleagues to understand who we are and what we do, and they can also have a glimpse into how we understand the way the healthcare systems run and how to make things better. I also think that we as anesthesiologists and as physicians in general need to use our voices, because the public still trusts physicians. And I think when there are important topics that we need to speak out about, I think that we should do so, because we have an obligation to humanity to provide them with information that's correct and factual about health conditions. I think it's also important that we speak to our legislators and that we participate in government when there are crises that need to be addressed. For example, drug shortages. And I've had the opportunity to speak out on multiple different subjects that have been very important, not just to the practice of anesthesia, but to the care of patients in general. The next thing is really to promote technology, not fear it. And I think this is actually a very critical point because, as I mentioned, we've had technology. This editorial by Dr. Achaban, I think, says it very well. For better or worse, we cannot resist technological advances. Our role is to manage those advances to the best benefit for patients, but also to avoid disappearing like travel agents and bank tellers. We need to be the drivers of progress rather than those who resist it out of inertia. When we look at an example of hemodynamics as one, blood pressure control, for example, a carotid endarterectomy, can be extremely high and low, stressful for the anesthesiologist, and even stressful for the patient physiologically who's undergoing carotid surgery. We've actually had closed loop systems for blood pressure control for decades, even though it hasn't been around. This article from 1994 shows how an arterial blood pressure transducer can be connected to hemodynamic medications in order to control blood pressure in a closed loop system. Despite the availability of these research results, we don't have this in our operating room, and it makes me wonder why. I think that the concern about threats to the loss of anesthesiology as a profession, I think these are overstated. We've had autopilot for airplane travel for years, and yet we still have pilots. And I think this is important because, as we all know from the miracle on the Hudson, that it's important that we still have human judgment involved in the care of very complex systems. When automated systems fail, then that's when we need to have a pilot, or in our case, in the operating room, that's when we have to have an anesthesiologist. But so many aspects of our minute-to-minute or second-to-second care may be enhanced by the use of closed-loop systems and technology, including artificial or augmented intelligence. When we think about the operating room of the future, I think it's very important that we consider different layouts. And this is just one example, of course, and this is not something that we have put in place where I work yet. But imagine having a control room that has one-way glass and can see into 4 operating rooms at the same time. When we think about our care models, we currently think about the anesthesiologist as being leader of the care team with human assistants, either anesthesia residents, anesthesia assistants, or certified nurse anesthetists. I think that this model may evolve over time, especially as technology becomes adopted within our practices. Imagine having maybe not quite robots, but closed-loop systems, may perhaps still with human assistance that could augment the ability of the anesthesiologist to provide care concurrently to multiple patients. This may be our future, but I think it's important that we explore technology and explore these opportunities before passing judgment. The other issue, I think, is looking at sensor technology and mobile health, because I think that as we expand the practice of anesthesiology into perioperative medicine, one area that we'll have to keep in mind is how we monitor patients as they leave the hospital and start to recover at home. Hospital stays are becoming shorter. Our patients are older and they have more comorbidities. And I think being able to get some of this automated feedback through sensor and mobile health technology, I think will help us to be better perioperative physicians. In addition, imagine preparing the complex patient for surgery ahead of time. Some of these mobile health technologies may also help us in the preoperative optimization or prehabilitation phase for patients. So finally, I think instead of being resistant, we need to embrace change. And I think we need to look at crises as potential opportunities. Change is the only constant, so we'll need leaders to take us into the future and lead some of these changes for us. We know that the opioid epidemic, which has primarily affected North America, is still worldwide. And I think that part of our ownership of the epidemic is really looking at the way we prescribe opioids safely. We can be part of the solution. And this is a group that I've been part of now for 2 years, the National Academy of Medicine's Opioid Collaborative, which has been extended for another 2 years. And we continue to work towards solutions that hopefully address opioid misuse, overuse of opioids, and hopefully provide treatment options for patients with opioid use disorder and reduce the stigma of addiction because it is a brain disease. I think a lot of these advocacy activities are important for us as anesthesiologists to participate in, because we can change our system. And by widening our scope and using our voice, we can really affect the care of patients far beyond our immediate care. I think we need to look for more opportunities, like, as I mentioned, preoperative preparation, prehabilitation, and we also need to look at issues of recovery, because although we've focused so much on acute pain, and some of our anesthesiology colleagues have specialized in chronic pain, there's still a big gap in this transition phase where we may be able to intervene sooner to hopefully prevent acute pain from becoming chronic pain. This transitional pain service described by the Toronto General Hospital and Dr. Clark, I think serves as an incredible example of how you can look for that gap that needs filling, and you can provide a service that didn't exist before. I think that we can also emulate Dr. Clark and the Toronto General Hospital's model, because we as anesthesiologists have a role to play in preventing chronic pain. And then finally, I think the responsibility of protecting academic medicine and protecting academic anesthesiology, it falls on all anesthesiologists, because if we don't have scholarly work, if we don't have research in anesthesiology, then anesthesia just becomes a trade profession. You know, we need to protect academics. Anesthesiology, if you look at this definition, is still a branch of medical science. The only way it stays to medical science is if we continue to do good research. And so I encourage all of you, even if you don't personally do research, that you support those that are conducting research and you support the science. You can donate to grant mechanisms, so that way the researchers of the future in our specialty continue to do their work. And I'll leave you with that. As I mentioned, I don't want people to think that there's no hope. We have plenty of hope, but the secret of getting ahead is just getting started. Thank you very much. It's a pleasure to join you.